There's just something about this work that's very personal for me.
Well, hi everyone, and welcome to this PESI UK event. Today and tomorrow is all about ADHD, autism, and trauma. And I am delighted that we have Sean with us, who is actually an autistic psychotherapist. He has a doctorate in clinical social work, and he's also a Mayo Clinic researcher, funded researcher. So welcome, Sean.
Thanks, Tracy. I so appreciate it. And welcome to our rabbit hole is what I'll call it today. And I use the term rabbit hole because I just there's there's just something about this work that's very personal for me. And so I'm going to start out with a story, because I think you come to people with this through a lot of journeys. And so I just want to share mine. Like all these diagnoses I carry, I work on them on myself. And so I consider myself my own object in study for this presentation here in the UK, and I feel honored to be before you. But my story, right? So when I was a kid, right, I had a pretty abusive family, and I had a psychiatrist at the time who, um, what he did was they brought me in because my fourth grade teacher had talked about how I was distractible, I was drawing, I was doing all these things, right? And so there were some concerns. And they were like, okay, this is concerning. Sean's mom and dad. And so they brought me into this psychiatrist who in the 90s, right? ADHD diagnosis was really kind of up and coming. And so he did his testing, he really got to know my parents, he got to know me. And somehow unknowingly, like he at least unknowingly to me, he diagnosed me with ADHD, and I think in theory he was actually trying to treat PTSD. And so it's a really powerful story for me because he told my parents I need to join this group, right? And the group was just sort of this outpatient weekly. He was a psychiatrist. It was outpatient therapy, um, and he was doing all this just therapy with a group of boys, and ironically everyone in the room had trauma, and I just wasn't saying mine, and I still haven't said mine out loud, and I don't know if I ever will or not, but it's pretty brutal. And if you read my book, there are some snapshots of it that I don't name necessarily openly, but they're in there. My book's through Norton, but anyways, we'll get there. um but he diagnosed me with ADHD, and it really helped because I got put in this group of boys who every single one of them was abused in some way. And they had these really open expressions of how they would get in fights with their parents and they would hit each other. And like, here's me, this boy, he's 12 years old, and this, like, my dad's a minister, and like it just it, like it had a degree of it that we just felt foreign to be there. But like it was funny because I didn't really come to my own understanding of trauma till one of my clients killed themselves at 31. But like then all these memories came flooding back, and it was like, oh, this guy was trying to help me all along. And so what I'm getting at is sometimes you diagnose one thing one way, and in reality, like your psychiatrist 20 years later might have like actually helped save your life. And so there's a power in like just knowing the things and being on the tip of the thing that may actually be the thing. But I see someone has their hand raised. So what I'm going to do is I'm going to take questions after the story now. And then I'm going to go through some slides. There'll be lots of opportunities to interact. And at the end of each, I want to say like 45 minutes or so, I'll take questions. If you have questions, put them. Tracy, is there a way that you can keep track of the questions, or Tabby, can we do that somehow?
Yeah, we have the Q&A that we can enable.
let's enable that. So let's have you put your questions in there, and then I'll answer these at those break. But a woman named Anne had her hand raised. Anne, are you there? I don't know if Anne's allowed to unmute herself, Tabby. Can she?
No, but she can put her question in the Q&A or in the chat.
Yeah, put your question in the Q&A, Anne, and I will answer that right now. But hello, everyone, and I'm glad you're here. Can't unmute. I have a question. Oh, I thought you had a question because you were raising someone. So Anne, I thought you were raising your hand because you had a question. But you can put your question in the Q&A if in the future you have a question. So I'm gonna dive in. Tabby, there's no way for them to unmute.
Not at the moment. No, when we get to a better point, we could maybe have people unmute later on in the day.
There are going to be points. So I'm a big believer in learning strategies that use active learning. And so I try to make a habit of not doing slideshows that I wouldn't want to attend. So I've got some slides in here, Tabby, where we're going to need people to be able to unmute. But I'm going to cap it at like 3 or 4 people at a time. Just because. Okay, so let's get moving. So our first module today, we're going to go over 3. We're going to go over assessment and diagnosis. We're going to go over a polyvagal model of autism and ADHD. And then there's one more set of slides that we'll get through today, but we'll get there. So when I think about autism, right, I tend to think about it in terms of neurobiology. And so I consider it a neurobiological condition that presents with cognitive inflexibility and decreased social engagement due to a chronic high level of stress, right? And that's typically measured in beats per minute or low heart rate variability. There's some other lines of evidence from mammalian evolution. If you look at oxytocin levels and vasopressin levels in primates, right? And then in humans, and there's a whole lot. And then there's anatomical arguments that I'm still sorting through, right? But really, like, there's a really solid evolutionary basis for looking at autism as a reflection of the nervous system. So I tend to work through this stuff bottom up. Full disclosure, I'm sensory motor psychotherapist. I'm in my level 3. I very much believe in the work of Pat Ogden. And so I come to this from my body to my mind, right? Not the other way around. I still say it's a relatively murky science, though, because there are 15 studies over 5 decades that say, hey, this is the case. And then there's studies every day that say it's not. So again, this is the challenge with having, right, like autism be this diagnosable thing. And so in the US, it's 1 in 36. I'm not sure what it is in the UK. But I have to imagine the number is growing because it seems like this number has been growing consistently over decades. So what's ADHD? So I'm going to play this cool video that I found on Psych Hub. Can you guys hear that, Tabby, or no? Or do I need to reshare? Reshare. All right, so let's go.
It was really pivotal.
I took medication when I was a kid. Everyone said I would outgrow it, so I stopped taking the medication in college. Everything is so hard now.
I hate math. It's so boring. I know I'm bad at it, even though my teacher says I'm not.
I'm a failure. I can't remember to do homework, I lose things, I can't get anything right.
I hate feeling like I'm different, but I really am. Work seems like it's easy for everyone else.
These are the voices of people with attention deficit hyperactivity disorder, or ADHD. Millions of American children, teenagers, and adults experience this disorder, which makes it hard to concentrate, pay attention, organize, and focus. Their lives are complicated because of it. I know. One of these voices is mine. I was diagnosed with ADHD when I was 9. Most kids with ADHD start to struggle with symptoms even earlier than that. I first noticed my symptoms in school when we began doing projects that took planning, and I got frustrated a lot. Later in middle school, I was on the basketball team, but I was always late to practice. Eventually, my teacher called my parents to talk about my grades, since I understood the material, but didn't turn things in on time. At that point, my parents, my coach, and my teacher all compared how things were going. And that's when my parents took me to see my pediatrician. ADHD can show up in 3 different types: inattentive, hyperactive impulsive, and combined. My symptoms were more of the inattentive type. I was having a lot of trouble losing things or forgetting things, not finishing homework, and organizing my work for projects and future assignments. My parents told me at first that they wondered if I had a hearing problem, because sometimes I would look like I didn't hear them when they talked to me. Other children also struggle to keep their attention in class, can look super distracted at home and school, and have trouble with details for things they're not interested in. Kids with more hyperactive or impulsive symptoms have trouble waiting for their turn. They might get up from their seats in class, run around when it's not a good time to do that, talk all the time, interrupt people, or blurt out answers. A lot of times, kids with ADHD can get into trouble, since the symptoms can look like they don't care or aren't respectful of others. But they do care. They just can't control it because of their problem with attention. While some people might have inattentive type and others have hyperactive impulsive type ADHD, still others might have symptoms of both, which is called combined type. If people show 6 symptoms from either of the first 2 types, or a combination of them adding to 6, they fit the diagnosis. While ADHD is most commonly diagnosed in kids, almost all of them continue to experience it as teenagers, and a majority still have symptoms as adults. Only some people grow out of it. The most important thing to know is that treatment for ADHD works. For little kids, this is behavior therapy that also includes their parents, so the whole family can be part of the solution. For school-aged kids and older, the best choice is medication or a combination of medication and therapy. I had behavior therapy where I learned some skills, like specific time management and organization techniques, that helped me in school and in my sport. I also took a stimulant medication that helped me focus my attention. Sometimes people find great help in non-stimulant medications, especially younger kids. For most people, ADHD medications really help focus and block out distractions. ADHD is a serious challenge for kids, teenagers, and adults who struggle to pay attention and focus in many parts of their lives. But there is hope. Treatment works. School wasn't easy for me, but with my therapy and medication, I learned what I needed to do to make it work. People go on to do well in school and succeed in their lives and careers, in spite of and because of their ADHD. I know. I did.
Just think it's really nice to hear authentic presentations like that from people who live it versus just this experience of we go through it and we don't know about it, right? And so there's a lot of overlap, right? And that's why I used the term murky in the first slide, right? Like this is just autism and PTSD. I mean, there are so many overlapping symptoms, right? I work in community health, right? And so what that means here in the United States is we get everybody who's poor, not able to afford care, right? And I call it the United States like form of socialized medicine. I don't know that they would feel the same way, but like we really do treat the poorest of the poor, and we get tax incentives for treating the poorest of the poor. And so I get a lot of people who people don't know what to do with because there are just so many things going on, right? And as you can see in these bubbles, right, there are just so many overlapping issues. You can do the same for obsessive compulsive disorder, right? So a lot of my work, right, when you pair with, right, like my personal experience of autism, ADHD, and PTSD, right, and people coming through the door and having this doctorate and doing research, right, and being really up on the things, like it's really about parsing apart what's going on. Like a lot of what I find I do in community mental health is slowing down. And it's sort of, I'm putting my hands up, right? Because like, it's sort of this motion. It's sort of a, hey, you got 1,000 thoughts here, right? Like, and there's like the speed about it, right? Like the hypervigilance or the impulsivity, give whatever clinical word you want to it, right? Like this, there's this element of quickness about it that's just really like, I feel like I got to do this. Because you get therapists, right? And they're like, I think this is autism, but I'm not sure because there's this, and this. And so what we're going to do is talk about a couple ways that hopefully we can distinguish some of these. Again, ADHD and trauma, right? I come back to my own story, right? Like that guy could have known, but when you think about who my dad was in the community, right? Like, and you think about how he was a pastor, right? Like if this psychiatrist said, hey, I think you're traumatizing your kid, he never would have seen me again. And he never would have helped me. And he did help me. I'm on medication still because of him. I never would have got diagnosed with ADHD without him. I never would have known that I had trauma that I repressed for 20 years, right? Because how we come at it in the room with people is just as important as getting the accurate diagnosis, right? And that's one of those things I just learned at this really early age and like came to know as a 30-year-old, right? Oh, hey, like how I present this, right? Like might really matter because people might leave and never come back. And then I can never really do the things, the parts of me that want to help do. And so this psychiatrist was just so skilled at that. So this is OCD and autism. And so when I'm like sorting with people, what is the thing, right? Usually I don't start with, I know the answer. I start with, I want to gather as much information about the body as possible. And the reason I say the body is because I think a lot of what gives rise to the symptoms of autism or ADHD really has to do with the dysregulated body. But we'll talk about those, that a little more in a bit. But we're going to just take this from a straightly psychological and psychiatric perspective in this exercise. So we're not going to talk about the body as much in this exercise, but we'll come back to it, I promise. Okay, giving you guys some time to get that down. All right, this is a point at which I think we're going to need people to be able to unmute. I would normally split you into 3 breakout groups, but there's 400 of you and we have 5,000 or 6,000 people enrolled. So the problematic nature of this is that, right, like, there's quite a bit of challenge, right? So this is going to require you to use what I've taught you so far. Did anybody not get the slides I just showed? Because you're going to need those for reference. Or did anybody not take a picture of them? Okay, so I'm going to go back for Miriam and the other person. I'm going to give you each like 30 seconds to take a picture. You will need these. So, and then we will. All right, so here's slide 1. Okay, here's slide 2. Yeah, it might be Megan Neff is what I'm seeing in the chat. I just know her as Dr. Neff. I guess I've never actually paid attention to what her first name is. She's great though. But I'm going to go to the final slide. And then we are going to get into some activities. Because again, I think learning is an active exercise. My brain needs activity. So I think this is really, really helpful thing. So I'm going to give you guys an example, and then I'm going to ask you some questions, and I want you guys to just respond either in the chat, and we're going to just take it slow because I think learning has to like sink in, right? Like it really is a process. But so I'm going to talk about, so when I say community-based therapist, I'm talking about community mental health. And what that means is the therapist I'm referring to serves the poorest of the poor. I don't know what the UK equivalent for that is because you guys have socialized medicine and everything makes more sense in that sense, right? And in Canada than it does here for those reasons. But, you know, just that's the frame culturally that I bring from the US to this example. So a 36-year-old Black female unemployed for 3 years is referred to you by a community-based therapist as they heard you're about your specialty training from PESI. The woman Ida reports difficulty going to work and connecting with others, and reports needing to go to the grocery store at nighttime as things are quieter and more orderly. Part of the reason Ida goes to the store at night is that in the past, a group of men commented on how pretty her dark skin was during the day one time. They were all white, cornered at her car, and took turns hitting her, asking her if she was going to vote for Donald Trump or not. So this is a group that's pretty, I'm not sure what the UK equivalent of this is, but they're pretty extreme in one direction, right? So they tend to be one of the more nuanced things about this group of people in the US is that, right? Like this group tends to be more poorly received by racially like African American communities in the US. Thankfully, someone called the police and they were able to apprehend some of the members of the Oath Keepers in the parking lot. Oath Keepers, again, are a group that got prosecuted a ton in the US because of incidents like this. However, now Ida is unable to go to the grocery store during the day now. So she has this sort of experience of anxiety for going to the grocery store during the day. However, she reports she is attempted to go with a group of friends who has cursed out or who she has cursed at or out when she is asked to go with them to the store. She reports traditional CBT and DBT have been ineffective, DBT being dialectical behavioral therapy, CBT being cognitive behavioral therapy, and wants to get this diagnosis for what we call Social Security. Social Security is a form of guaranteed income, right, as related to having a disability. In the US, I'm not sure how it is in the UK. You actually have to prove how bad things are, right? So like they don't just say, oh, you need support, you get it financially every month. You have to like go through this grueling process that most people lose 3 times that takes 9 months of time. So that's sort of the setup, right? So she's here for this diagnosis. And so I'm going to ask you guys some questions about this example, and I will go back to the example as we ask these things. And I'm going to ask for people to just, it looks like there are a couple of people who Tabby asked to share. But I'm going to have those of you who raised your hand to share to try to answer some of these questions. So if you want to answer the questions, raise your hand. I'm going to go through each individual one. And then for the last question, I want you to put in the chat, or can we do a poll, Tabby? Is that a possibility?
If you just want to let me know what you want
So
included in the poll.
Yeah, so the poll is, I want to see if people think it's OCD or PTSD. And then I think we'll have to do the last part of the question in the chat, but we'll do the last part of the question in the chat. Does that sound okay?
Yep.
All right, cool. So for those of you who raised your hand and are open to sharing, in this case, what examples of cognitive inflexibility or restrictive repetitive patterns of interest or behavior are there? And I'm going to put this back up. And I'm going to call on Miriam. Miriam, what are you seeing?
Sorry, it wasn't me. I only put my hand up for the slides again. Thanks.
That's okay. That's totally all right. Do you need me to go back?
Okay, maybe at the end. I don't want to
Yeah,
disturb
no,
the whole
we'll
group
put the
of
slides
400.
and we'll have the slides come to you in a bit. So they'll be there. How about Helen? Helen, what do you see as far as restrictive repetitive patterns of interest and behavior in this? Like, why might this woman think she has autism? Helen? All right, I'm gonna come back to Helen. Jess, you raised your hand. Can Jess unmute?
Yeah. Okay.
I can hear you. Hello.
Yeah. No, I just think because she wanted a grocery store quieter and more orderly is
Sure.
a potential sign.
So there's this real need for order auditorily and like light wise.
Yeah.
Yeah. Yeah. I mean, that's very restrictive and repetitive, right? It's restrictive in the sense that she can't go during the day. It's repetitive in the sense that, right? Like it's got to be at this time of day, right? It's a way of organizing it. Good job. Any other takers? And I'm gonna look in the chat here. Difficulties going to work. I see one other hand raised besides Jess's. Jess, Veronica, you look like you have something to add. Go ahead.
Hi.
Hi.
So I would want to know when that event happened and if some of those behaviors were happening before that event.
Sure. So
like,
I can go ahead.
Difficulty with going to work and connecting with others. This for me is like
this could be a whole thing, right?
This could be anything, yeah. So I'd need more information.
Sure. So you'd want to ask more questions. I gotcha. That I will tell you, this is a real case that I had. I just tweaked some of the details. So this is a real person, right? Like this is somebody who went through this. So, but good feedback. Jess, do you have your hand raised on purpose, or is that just kind of hanging out there for you? Okay. CBT, GBT. So restriction could be once to go to the grocery store at night. Veronica, did you have another one you wanted to add, or are you just raising your hand by accident?
No. I wouldn't rule out that there's two things running alongside here.
Sure, I wouldn't rule that out either.
You know, and it's just kind of like, I'd be careful. So trauma can sometimes look like ADHD or ASD, but that doesn't mean that's not running alongside it. So you have to unpack both.
Right. And I mean, I think, right, like this woman's coming in telling you, hey, I can't work, I can't go to the grocery store, I can't do therapy, right? I failed at CBT, I failed at DBT, right? Like nothing is working. Like, so there's this inherent belief of I'm a failure that I think you're touching on, right?
Yeah.
Like deep sense of there's something deeply wrong with me. And
just
I mean,
a bit more complex than just like I need a diagnosis.
Well, right. But I mean, usually that's why people come to us, because they think, right, if I could get this one thing, like this person's thing was, I think I can get Social Security, right? Which in the UK probably doesn't mean a lot, but in the US, right, I can get income for being disabled, right? Like I can have a safety net, because the US doesn't have a safety net. That's not a thing we've invested in, sadly.
Yeah.
And I have lots of feelings and thoughts about that. But
yeah,
I think right, like this person comes to us without really sort of a clear sense of what they need, right? Hence part of why we're spending some time today on thinking about assessment, because assessment is more than just giving it a label. It's what am I going to do to help this person? In this example, are there any examples of social engagement or communication difficulties, either overt or covert? Covert meaning they're not so obvious, but hey, that might be a thing. And feel free to put them in the chat or raise your hand. I gotta scroll up here because you guys have a huge unemployed. Okay, yeah, could be. Ida has experienced a racist attack recently, probably more in the past too, more than likely. For this real person, they had lots of microaggressions. And that's a thing in and of itself, right? Like cursing out the friends, right? That's a pretty overt one. So I'm seeing lots of great noticing happening here. Difficulty connecting with others. That CBT and DBT didn't work for them. That's a really interesting point, Sarah. Can you tell me more about that? Because I think you're actually touching on something that I'd be curious about. If I were working with this person presently, if you feel uncomfortable speaking in front of everybody, just put that in the chat and I won't call on you. But I'll come back to you. I'd love it if you'd offer your hand and speak to the group. But Roger, I'm going to call on you first because you raised your hand. So go ahead. You can unmute, Roger.
Hi, sorry, I was just looking for the unmute button. This
Okay.
to me looks really interesting, but there's a lot, as a couple of people have said, to unpick. One of the things that I'm interested in here is she has attempted to go out with friends. So I'm curious about what that means. What's the background there? Who
Sure.
has she attempted to go out with? How close are these friends? How long has she known them? What's happening when she's with them? How does she feel when she's with them? So she's got the idea of being with friends, but it sounds like she's not able to do it. So I'm not sure who said it, but somebody suggested that there may be some possible PTSD symptoms from her history. So it is, having a discussion, having more of a discussion with this lady. What you have said that's interesting is about the social security, and we do have something similar here in that you've got to prove it. But what I find particularly interesting is she's come to you looking for a diagnosis, and actually, even though you want to help her, you can't just give her one, which may be disappointing for her. So I'd be interested in how she reacts to that.
Well, right. And how you manage that disappointment, right? Like, is a process in and of itself. I will tell you that the real client I worked with that I did this, we started with that, but we worked together for 4 years. I actually just discharged him because he had really intense depression, and that seemed to be treatment resistant, which is its own lane of things, right? But does affect very similar things. But, like like these cases that come to you in community health, right? Like tend to be more complex and tend to be the ones other people pass over, but they are definitely the greatest teachers. And so, as far as the group of friends goes, I think they would have been a group that was close to her. But I think, right, like, so US history, right? Donald Trump went out of office in 2020 and was going into office in 2024. So her friends, right? So this event would have happened somewhere from like 2021 to 2023, sort of reign of time. So, I mean, it would be very fresh for her, I think. But usually the thing about fresh wounds, right, is that they're old wounds, right? Just re-brought up. Because again, someone brought it up. She's probably experienced lots of microaggressions. Yeah, she has. No questions. So I want to look in the chat here so I don't miss being a female. Right. And then there's the whole dynamic of being female, right? We didn't even touch on that. God, there's so much good content here. I don't know, Tabby, if there's a way to preserve the chat, but I think this would be really useful to those who watch it later to see. Or is it just what I highlight, Tabby?
Just what you say verbally.
Okay. PTSD. So now you guys get a chance to vote. And I'll tell you what it is for this example and then what it was in real life. All right, so who thinks it's OCD and who thinks it's PTSD? So I'm getting a very clear sense here of what you guys think, which is the vast majority of you think it's PTSD and some of you think it's OCD. So I'm gonna stop sharing results of this, but I mean, it was like 97% PTSD and then the other was OCD, right? You guys got it. This was PTSD. In real life, this was both. We didn't put that as like an example. CBT and DBT were both ineffective for treating Ida's cognitive inflexibility, right? That means there's something enduring about this, right? Typically, when we treat with CBT for something like cognitive inflexibility, it's rooted in something, right? Like this is why when people come through the doors, sometimes labels are not a very helpful thing. It's useful for us clinically, but I don't know it's so useful for them. There is no recorded use of trauma-based therapy being tested, leaving serious question as to whether or not this is PTSD or autism, right? So one of the things I always do before I even consider diagnosing autism with diagnostic strategies I have personally is I make sure there's an evidence-based practice of PTSD treatment, right? So EMDR protocol, sensory motor psychotherapy, IFS, TFCBT, take your pick, right? But if that has not been tried, right, the chances of it being autism are pretty low. In my book, at least for my willingness to even diagnose or explore, because, right, none of that's been tried, right? Like it has to be tried. We have to know it doesn't work before we try something else. PTSD has the presence of lack of social engagement and sometimes that impression of rigidity, right? Additionally, there's a negative change in affect, which is presumed to be intrusive memories. What happened with the Proud Boys, right? So when she tries to go to the grocery store with her friends, and there's that right, like sort of reaction, it's rooted in this implicit memory. Sorry about these. It's rooted in this implicit memory. So gold standard measures, right, are things like for autism are the ADOS-2 and the ADIR, but they even have a frequency of failure 25 to 35% of the time, right? And so autism by our medicine here in the US is considered lifelong and enduring. The truth and accuracy of that is in question, but diagnostically, it's a helpful place to start. We could probably have an hour conversation on whether or not this stays for life or not. So Emily, I'm going to have you try to go now if you're ready, because you have your hand raised and you've been so patient, and then you got your mic working. So Emily, are you ready to go? Okay, Emily lowered her hand. I'm not quite clear why, but that's fine. I want to go into the chat. The symptoms started before. I'm just looking here to see if there's anything I'm missing. Yeah, burnout for ADHD is often misdiagnosed. So I don't actually adhere to any other kind of burnout besides burnout, because the person who researched this, to my understanding, did not really think autistic burnout was a concept that was going to take off. And so if the intention wasn't there with the research to begin with, so, and to your comment, Denise, I think they're working on it, right? They're doing an ADIR2, right? But the research is where the research is, and you know, it's not perfect. I know the DSM-5-TR really does account more for women and minorities. And so I'm optimistic about that. I'm also aware that it's not perfect. And there's a lot of good research coming out on autistic experience of women. I'm trying to think of who is doing that research, but it's not coming to mind. But I'm sure if you Google it, there are lots of people. I know there's a lot of really great research on ADHD in women. So we are actually taking longer than I thought. So I gotta think here for a minute. And we should be okay. I just want to look at my power for my computer really quick. What am I at? Now it works. Okay, now we're good. I don't know what the hell is going on with the outlets in my house, but apologies for that. All right, so okay. So there are a couple studies, one by Vassil et al. In 2022 that looked at 214 kids with autism who were diagnosed with 214 5 to 16-year-olds with autism. And they found a rate of 34% false positives, meaning like more than 25% of that cohort, right, diagnosed with the ADOS-2, right, was found negative. And you know why? What we just looked at, trauma, right? So again, my friend Brenna Maddox from UNC Chapel Hill, she's actually leaving Chapel Hill, did a similar study and found 75 adults assessed with autism by the 802 and with psychosis, and there was a false positive rate of 30%, right? And then finally, back in 2006, there was another one of the 802 and the ADIR that found a rate of 30% false positives, right? So there's a 30 to 35, I like to say 25 to 4% positive or false positive rate. And the key being, right, PTSD. And I think this is important to notice because, right, I make a point here, if there is no recorded trauma therapy being tested, this leaves serious question. And the makers of the ADOS and the ADIR will both tell you it is not their job to determine whether or not someone has autism. It's to help inform a clinical opinion, which is why you're here, because it's about assessment, right? So good assessment means, which I don't know enough about psychology graduate education to really know if this gets taught or not, but when I look at ABA clinics, right, that operate for the 3 to 5 year old cohort, I don't think a lot of those people are looking at PTSD as an entrance criteria. And I have to wonder how it would affect their diagnosis rates if they did. And again, maybe some are, maybe some aren't, but I do not get the impression from behavior analytic people that I love and cherish that they really get a ton of education on DSM-5, right? Specifically with disorders other than autism, right? Because that's where a lot of their market is. And I'm really referring not necessarily to the people who go on become board certified behavioral analysts, but more along the lines of people who they go to school for developmental ABA, right? Like they do RBT, they come up as an RBT, they learn it in the trenches. Like I've worked in those spheres before as a behavior tech, and we never talked about anything besides autism, right? Which leaves questions for me about, well, like if you're not looking at the whole thing, like maybe we have some bigger issues here, right? So we're gonna do another one. A 14-year-old trans male comes to your office with his mother, his name is Fee, and describes challenges around school from early childhood on. He reports that he gets stuck on things the teacher says that are inaccurate, like the sun being 93 million miles away versus 93.6 million miles away. It actually is. He reports a love of Yu-Gi-Oh cards and reports no concerns of bullying. His prior therapist thought that he might have obsessive compulsive disorder, given the way he gets in open conflicts with his teacher in front of the class, and when she gets details about topics of learning wrong and appears unaware of the social consequences of his actions, despite repeated times of being sent to the principal's office. He underwent a summer of exposure-based cognitive behavioral therapy, which helped improve his social functioning, but still has not resolved any, has done nothing to resolve when others get details wrong. He comes to you wondering whether or not he has autism. So we're going to go through the same questions again. This time, though, you have the pleasure of experience. I'm thinking there should be a third rail here, but Tabby, for the poll question, Tabby, let's make autism one of the answers. Would that be okay?
Yep, no worries.
I know my thing only says OCD and PTSD, but I think there's a decent possibility here that it could be autism as well. And this is an actual case again, right? Like where I assessed it, I thought it was one thing and it turned out to be another, because these things are murky and they're not easy and clear. And that's really what I'm hoping you'll take away from this first module, is that this is murky work and you have to have a degree of like willingness to be wrong. So I'm going to ask the first question and then I'll call on you, Jeanette. If this in this case, what examples of cognitive inflexibility or restrictive repetitive patterns of interest or behavior are there? So I'll put this back and then Jeanette, why don't you go ahead? Am I saying that right? Jeanette, you're welcome to unmute. So Jeanette, I'm going to come back to you because you're not unmuting for some reason, but Sarah Edwards, why don't you go ahead? Tabby, can they unmute?
Yep, they should have the ability to unmute on their side. Jeanette and Sarah, if you look to the bottom left of your computer screen, you'll be able to see where you can unmute.
Oh, while you guys figure out how to unmute, I'm going to look in the chat here. I can't. Oh, okay. Feel free to put in the chat what you think, Sarah. There's no camera or mic in the left-hand corner. Apparently, there's not a mic in the left-hand corner, Tabby, for some of them.
For Alexandra, she currently doesn't have her permission to talk.
Got it. Interesting. So, okay. I am reading ABA is abuse. Well, there's some complexities to the ABA discussion that we can talk about during the Q&A if you want. And what's ABA? It's a good question. There's a lot of layers to it. It's a lot of things, but we can talk about it broadly. So I'm like a therapist. Okay, so I'm looking for examples of restrictive, repetitive patterns of interest in this example. I'm just trying to find them. Let's see. Where are they? Window of tolerance. There's some things about the window of tolerance that we'll get into in a bit. That's the next part of this discussion. So, okay. So I'm seeing lots of comments about ABA, but I'm not. So the Yu-Gi-Oh cards, right. Being stuck on the teacher being wrong, right. Okay, so you guys are seeing, so the Yu-Gi-Oh card, the details, yes. You're picking up what I'm putting down, which is that, right? There are some details, right, that he might know and he's not considering the social consequences for. Like the Yu-Gi-Oh cards being right. What about examples of decreased social engagement or challenges to social communication that are either overt or covert? Let's see what you're putting. Getting into an open social conflict. Yes. And I think the way it happens, right, tells you a lot about it, because sometimes we can disagree without it being a problem. But it depends on the other person's window of tolerance. Conflict in class, right? Not interacting with peers. Yep. All right. So you guys all have great thoughts on this. So I'm going to keep us moving because we got so much to get to and so little time. So poll question. Tabby, let's put it in the poll. Let's see what people do. So a lot of people are saying autism. You know, if you guys were with me when I had this case, actually, like, my life would have been much easier. Because I did not think this was what it was when I started with this person. Because I only usually meet the vast majority think it's autism. So let's see what it is. It's autism. So you guys were right. The vast majority of you were right. Let's put it that way. In this case, we know that social engagement and cognitive inflexibility are both present. Lauren, I will come to you momentarily, I promise. There is no history of trauma despite some concerns in school life, right? So we talk about how there's no bullying, but there is some concern of, well, hey, you're getting into these open conflicts, right? So to be fair, in the real example of this that I had, the person came to me and we hadn't tried exposure-based cognitive behavioral therapy. So one of the things I always look at, again, is if there's presence of anxiety, then I need to be sure there isn't OCD. Because I mean, so it's kind of unclear in the literature whether or not a person can have both. I tend to be of the school of the thought that you can't, right? Because, and again, I caveat that with there are exceptions to this. And And so, but the vast majority, right? Like we think about a restrictive repetitive pattern of interest, stimming, right? Like I do this thing, right? Like I'll just do this very subtle somatic resource, but it's still repetitive and restrictive, and it's kind of interesting to my brain, right? Like that and hair scrunchies, right? If I ever have a girlfriend, I'm stealing those. But like, right? Like, but the thing is, right? This is soothing. It's not intrusive. If it were intrusive, it would be OCD. And so when I met with this person in real life, right? Like it was like, you need to go try this exposure therapy thing. The thing made their social skills improve, but it didn't actually fix this underlying thing, right? The restrictive repetitive patterns of interest. So typically when we diagnose, and or more specifically, when we assess, we really want to rule out OCD. Or we really want to, because again, when we think about how medicine thinks about autism, whether or not it's lifelong and enduring versus an anxiety disorder, anxiety disorder, we have a lot more literature on exposure-based CBT treating and actually resolving OCD or making it much more manageable. Like you guys got the Yu-Gi-Oh cards. It's not distressing is the subtle thing, right? Like he really enjoys this. That's the, you guys caught that it was the restrictive repetitive pattern of interest, but like when you go the layer deeper, it's what's the orientation of this? Is this towards me and hurting me, or is this something that, right, like really makes me happy? So given that is diagnostically relatively clear with no overlapping symptomology from OCD or PTSD, it's feasible to think that this is a case where there's not diagnostic overshadowing. Diagnostic overshadowing is we think it's one thing and the shadow of those symptoms sort of outlies something else, right? Like I work with a kid where he has autism and all this pain, and there's this just like this diagnosis buried in the dirt of ODD, right? And he's not eating and he has a G tube and there's all this stuff, but like the thing that I haven't really addressed, right, is that there's this diagnosis from 2017 that I haven't really considered, and this doctor makes a comment, and so I have to go back and look over here, and it's complex, it's not simple. So yeah, he also had difficulties with social skills early on in education. So we're gonna go to example C. So 16-year-old female named Justine comes in with a history of anxiety. She reports she worked as a waitress and had difficulty making small talk and eye contact with stranger. There is nothing odd or scary to her about these individuals, but reports having difficulty when they come in with clothes misbuttoned or stains on their clothes and cannot refrain from commenting on these. She might say something like, well, that you see that there, right? So she points it out. So it causes her a bit of a rough time with tips, right? Because in America, waitresses don't really earn salaries beyond like a couple bucks. Most of the time they live on tips. So she's been written up at work for several times, and her therapist was referred her to you because, again, you have this PESI certification on whether or not. So I want to caveat with, in the US, unlike in Canada, and I don't know how it is in the UK, you actually have to prove that you need an accommodation. You don't just get one. Whereas I know that's not the case in Canada. I'm not sure how it is in the United Kingdom. But this often, right, like I'll do these talks and sometimes people will be very like, why should we need accommodations? Like, why is this a thing? And so the thing I often have to talk about is how in the US, right, like we don't have the luxury of socialized medicine. We have the challenge of, right, like actually needing to seek workplace accommodations, and we have to actually demonstrate that it's a problem. It's why this whole social model versus medical model disability thing I find so frustrating, because I think the social model completely misses the realities of some of my clients. So again, same questions. And again, that third question, we're going to make all three, Tabby. So again, what examples of cognitive inflexibility or restrictive repetitive patterns of interest or behaviors might there be for our client Justine, who was referred to you because of this wonderful PESI certification you got? And feel free to hold. Let's not put the poll question up yet, Tabby. Let's take that down for just a second, because I still want to go through my first two questions before we do that. So I'm seeing you guys picking up on minor details, pointing out the stains on people's clothes and customers. Yes. Yes, she is. What are the problems with the social model of disability? We'll come back to the social model of disability thing. Compulsion to mention the stains and misbuttoning, right? So, okay. So you guys got that one. How about the social interaction difficulties? It would be hell to work as a waitress, I agree. The lack of eye contact, the difficulties with small talk, right? The blunt speaking, well said, blunt speaking, very well put. All right, now you can put the third question, Tabby. Let's put the poll question up. Let's see what you guys think. This one's not so clear. And part of it is, right, like, I want you guys to understand the struggle of diagnosing this when somebody walks into your clinic, right? Because these things aren't clear and easy, especially when you work in community health and not a university hospital, right? Because university hospitals have the luxury of like picking who they see and how they see them and how quickly they see them. And there's just a whole slew of ways we diagnose that demonstrate privilege in my mind. So this is interesting because we've got sort of a 30-60 split, and none of you think it's PTSD. I'm somehow not surprised by that. But I'm hoping what this is getting at is this is murky, right? Like this is not simple. This is sometimes not a question you need to answer to help a person, but it can be to help you help them. All right, so we are going to stop sharing. So we got a 34-66 split. All right, so what is it? What was it? I'm trying to remember the real example of this. It was OCD. So the obvious statement of there's a history of anxiety, right? I'm trying to think where I put it. Where is it? There's a history of anxiety. It's right there, right? So that's my starting place. When somebody says, hey, I have anxiety in my diagnosis list, OCD, first place I go. There also doesn't appear to be an aversion to customers that would be in the trauma case, right? So that like avoiding people like physically, right? There's a thing about that would happen if it were trauma. There does appear distress around clothing stains, right? So that is internally distressing for Justine. I almost said Tabby, but Tabby is the person who's doing all the wonderful Pessy magic. So she's not the one in the example. So while there is difficulty with social engagement, yes, the laugh emoji is well placed. While there is difficulty with social engagement, which has reached a dysfunctional level, it's a byproduct of difficulty with these intrusive sort of things. Commenting on these details appears to be a way to verbally comment on behavior. And so I want to come back to what's the problem with the social model of disability. I don't know that it is in the UK like it is in the US, right? So in the US, in order to get Social Security, an IEP, accommodations in school, right, that schools have to follow, or to get a accommodation at work, you actually have to prove you have a disability. You have to prove there's a thing that happens. People don't just go, oh, I'm going to respect you. Like that's not a thing here in the United States. And my sense is that it is in other parts of the world. I know it is in Canada. You can just ask for an accommodation, but you can't here. You actually have to have a medical diagnosis. So for me, I mean, we'll come back to the OCD comorbid question in the questions if you put it in the Q&A. But like for me, the important thing is that my clients are protected. So when people say this is just a personality thing for me, I have no problems, right? Like autism shouldn't, or ADHD, right, should not be considered a disability. It fundamentally undermines the challenges to the legal system that we have here. And it doesn't really acknowledge in a cohesive, coherent way. Like, yes, it would be great if society could just change and support us, but in the United States, we just don't have that luxury. I don't know what it's like in the UK. I hope it's different. But again, that's my issue with the social model. You have to prove yourselves too. Okay, so again, I think it depends on the country you live in, right? Like So what I'm seeing is that in the UK, this is very similar. I feel like we could do just a talk on this, right? Like this could be its own thing. It's much harder in the UK, but depends on the government. That's interesting. I so don't understand the United Kingdom. I so want to, but I just am very naive to it. Okay, so let's see what's next. So I actually have some recommendations here for you guys on where you can get some training for something that's really usable. It's called the Autism Mental Status Exam. It's very accessible. It's free. All you have to do is take this training at this link, and we'll send you the slides at the end, so you'll have these. So don't feel like you have to write them down or take a picture or something. But I'm going to go through this. I made a smart phrase because we use Epic at the organization I'm at, and basically just loaded these in there and gave them a 0, 1, 2 rating, right? Because 0, 1, 2, right? And they have to score 5. And so what I do with people is I have them, it depends on how they're coming to me, right? So if a therapist refers them to me, I always have the therapist in our clinic system do this first, because I never want to be the only one, like, because I'm not a psychologist, I don't do the ADOS-2. I'm a clinical social worker. My doctorate is in clinical social work. The nuances of that matter in my world. They might not in yours. But only psychologists can bill for testing because of some arbitrary arcane rules that make it really difficult to get people out to autism diagnoses and create all this systemic privilege, right? Where schools can say, we're not going to give you an IEP because you can't find, we don't have a psychologist saying this. This is a social worker, right? It's infuriating. So we're working on it, right? Like work in progress. But like this tool is very helpful because, right, I just go through this with people, and I use this, and I use the body perception questionnaire from Stephen Porges, which you can download for free as well. I didn't include that one because I don't think that is as easy to explain or would fit in our time strains today. As far as ADHD goes, the Connors and the Vanderbilts are both really great tools. Whenever it's ADHD or autism, I'm really looking at these more fundamental underlying questions, which might sound weird for me as a therapist to be considering, but I work bottom up. So I work at, what's your digestive tract look like? Are you having neurological activity? I can't tell you how many kids come in, right? And they're having some form of like, I'm dissociating or like leaving my body, and like the parents are complaining that like they're not doing their homework. So it's like this real weird place of like, what of this is will? What of this is neurological activity? So that's a thing that can happen, right? There's sleep problems. There's cardiac health issues, right? Again, autism, ADHD, much faster heartbeats. I don't know about the ADHD so much. I know for autism, that's been proven true over 5 decades and 15 studies. No one's come out and said this is for sure true yet, but I feel like we're getting there after 50 years. I say that, right? But like, it's not an established fact. I don't understand why. Like, life expectancy in autism is shorter than those without. ADHD, right? There's a lot of evidence to link that fast heartbeat to like that distractibility. I'm still kind of working through that on a polyvagal level, but there's feeding behavior difficulties usually in these populations. There's diet challenges, and there's bowel movements. And believe it or not, I spend probably half my assessment just going over these things. And reason being, I think these things that happen in the body give rise to all the rigidity and all the social problems, at least in part, a significant part, like a part that is substantive enough that I'm spending just about half of my assessment worrying about these things, because each of these things can cause a heartbeat to go faster. And so I think about these things. What is a person, is a person eating or not? Is a person sleeping or not? It's not sexy, but it works, right? Like I've got a kid right now we're working on going through, like he has bowel movement, like he poops every time he's anxious. And so like he poops throughout the day. And so like we're working with the school to just figure out how do we make this kid less anxious so he poops less, right? Like these things, right, are totally related and might not, again, be sexy, but like are actually really important to people's health. So I'm going to answer some questions here. We got 16, so that's quite a few of these. Tabby, do we have time for 3 modules, and when is our break coming up?
Let me double check the break time quick.
I'm going to stop sharing my screen for a moment because I want to look at the slides, and then I'll get to answering some questions because I want to figure out what we're doing here, or what I need time for here at least. Okay, so some of the stuff, I'm going to have to cut some of the stuff just because of how much time this is taking. So I have one activity I'll cut out. I care more about you guys having things you can take away and use, so I will just cut some of these things that I think are not relevant. We'll still touch on them, but we won't do the activities per se. But let me answer some questions while Tabby tells me when we're taking a break. I think it's coming up in 20 minutes or 18 minutes. Is
Yep,
it 18?
10:30.
10:30? Okay. I love that you're trained as a colon hygienist. IBS, ED, Ehlers-Danlos, right? Like hypermobility, all these things affect, right? Because body up, right? Like it's a thing. The mind lives in the body. Dan Siegel taught us that 30 years ago with developing mind. All right, so I got to go back to the beginning. I have a question. I have a 30-year-old client, adopted, birth, no evidence of PTSD. I go to their home for 1 to 2 hours, please. Bambi, can you give me more on your question? Because I'm not entirely sure what your question is. So maybe you could put it in the chat, or you could, a TRE provider, so body up also. I think, okay, so I think that last slide, right? Like looking at what is going on in the body that might be causing some of these challenges, right? It sounds like he's a lovely client. He or she or they are a lovely client. So it might be worth just like going through and seeing like, hey, are these I don't know why it's asking me to, okay, are these like, what of these are happening? Because the biology shapes the other stuff, right? And like when I say I work bottom up, I really do actually spend the time assessing because it's really important to understand the body. So to answer Melissa's question, right? Actually, the slides, they're coming to you. I'm going to send them to Tabby on break. So you'll get the right slides there. I don't know why you guys got the wrong ones. But you know, these are the mysteries. But to talk to the neurodivergence clients, I think, right, one of the things we have to be really mindful of that we aren't, because we're all taught to think about what's going on in the mind, how are you feeling, et cetera, et cetera. How you're feeling is directly intersecting with your body, right? So if I have irritable bowel syndrome and I can't move to wake up, like I don't have the energy to do that, that might be depression, but it's also, right, like I may have a ton of like cysts on my ovaries, or I might have a ton of tumors on my intestines, right? Like we need to be curious about these things, and we're not. And that has a lot to do with this mind-body divide, right? Thing that happens with brain being the origin of mind when it's probably not. Like it is an unhelpful frame for this population, I think, to not consider the body. How do you help clients with ADHD manage impulsivity in session and outside of session? So I can tell you how I do it with hypersexuality. That piece I'm gonna throw a caveat on. I don't know that I can really answer the hypersexuality thing in a way that I would a consult in this context. What I can say, right, is for myself, like there's going to be a module coming up on slowing down. It's in the IFS portion, right? But really for me, like I just was in a relationship for the first time where I actually was like, yeah, let's wait to have sex until we figure out this intimacy thing. Because as I've done the work on myself, I have more emotional awareness. And I was dating this autistic nurse, and she was just very, like, we got into the relationship, like after 1 week and 1 day, it was like, this is too fast. Like my things did this, right? Like naturally, I've been working at this. I had to consciously like go through it and be like, yeah, like I'm going fast. I didn't want to, but like it was sort of facing myself and saying, hey, like I'm going fast. I know these parts of me pretty well by now. And so like actually taking the time to like work through for myself, okay, why am I having these flags, right? Antenna are going off because there's like some lack of emotional communication happening here. There's a like I felt a lot with her, but there was no insight on her end. There was insight on my end. Like I felt and changed, and like and she would deny it. And like that defensive state tells me so much. So like I had to actually consciously be like, yeah, we're not gonna have sex until we figure out intimacy. So now like my dating norm is I have to like feel connected to a person before I'll even consider sex. And I actually talk to people about this. So I realize that kind of answers your question. Doesn't really. Again, you can reach out to me on LinkedIn to get a consult, but I charge for those. So, and we may or may not do a consult group. I don't know. That's up to PESI. I'm not privy to those decisions. They just say, hey, you want to do this? And I go, sure. Do you really think someone grows out of ADHD or gets better at managing it? I did. And then I decided to go back to it because my therapist thought it was a good idea. So I can totally function without ADHD medications, but yeah, to put it simply, I think you absolutely can outpace the symptoms. All right, I'm going to skip that one because the sections are grayed out with something covering the text. Sorry about the interruptions. Our organization just switched to Teams and it has all these functionalities I'm not quite sure of yet. And so sometimes it pops up messages. So I think that's what was causing the grading. So my apologies for that. Hi there. Would you be able to help understand that the diagnostic criteria shared is based from an American criteria? Sure. Is it, if possible, is it also possible to clarify the diagnostic criteria? So do you guys in the UK use the ICD-10 system, or do you guys use the DSM? So I think, to my knowledge, the DSM is a bureaucratic organization funded by the American Psychiatric Association. It's been around for 50 years plus, right? We might be at 70 now. I know that actually autism diagnostic criteria started in Europe, not the US. I have our little boss. I'm getting my people confused. There was a man named Hans Asperger and another contemporary of his. I'm totally blanking on the name of, what is his name? I'm going to have to get back to you on that other guy, but there were two European. So Hans Asperger was in Germany around this time of World War II. So in 1944, he started writing about Asperger's, which is part of the criteria for autism was derived from his papers. And so I can tell you that autism is largely built off white kids, yes, white boys, but they do happen to be European and not American. As far as ADHD goes, ADHD is kind of, it's again, a bunch of white dudes in Germany, right? Like, I don't know why that's the history of it, but that's the history of it. It kind of evolved from actually like the medieval ages all the way up through the early 1900s, and then the Spanish flu. So when the Spanish flu came around, they were seeing symptoms of people who went through it and actually came out, if I'm getting my history right, who looked like they had ADHD because they had the Spanish flu. And so it kind of coalesced in the 1920s as far as that goes for ADHD and autism. I can't take a picture. Totally, this seems to be a totally different workshop than the one advertising. The title's integrating different modalities. So we need to go into assessment and diagnosis to be able to do all the modality work. So yes, I understand this might not be what you think you signed up for, but I promise is what you signed up for. But we have to be able to answer those fundamental questions of what is the thing to know what thing to use. So I get that. I understand. Many of us have trauma, but not necessarily PTSD. How many appointments are offered? I'm getting lots of questions here. So we'll be doing the IFS, sensory motor, and CBT thing tomorrow. We're going to do polyvagal theory next. I understand that you feel like you're being misled. I promise you're not. You need to understand these things to understand where we're going. I wouldn't tell them to you if I didn't think they were super relevant. So I promise that we will get there. You just got to be patient with me. Because, right, like to do those things, we need to actually do these things first, because when you're working with a person, if you don't know if it's autism, PTSD, or OCD, you're not going to know what to use, especially if they're trauma modalities, right? I've done research on trauma interventions in autism. We will get there, I promise. But I do think this is really necessary, especially when we do studies, right? We have study entrance criteria, and we need to make sure that people meet the entrance criteria. And so I want to make sure the things we're talking about, you really understand what we're talking about. So how many of us have trauma, but not necessarily PTSD? Lots. Lots is the answer. Trauma is the experience of an adverse event, right? Usually ends in 60 days. Or 30 days or 60 days. I think the DSM says 60 days. Normal response, like withdrawing, having triggers, strong emotional reactions, right? That normally ends in 30 days or less. I don't know if you're limited to a certain number of appointments or not in the UK. I think it depends, right, is the answer. It depends on your coverage. It depends on how your systems work. I don't know how the UK systems work. Yeah, so this question from this anonymous attendee I really like. It seems there's a lot of presence of changing traits from the client and exposing them to certain things to change them rather than emphasis on accepting who they are, giving adaptable social skills while still upholding their own communication and letting them learn the best combinations from themselves and how to advocate for themselves. So that's a really good question, right? It's kind of a both and, right? When my clients come to me and they have autism or they have trauma or they have ADHD, it's like some of this I've been there before, right? The other part of this is what are they going through, which is really the more important part, right? It's more important for them to kind of come at it at their own. I do think, right? Sometimes my clients come outright and say, Sean, what am I missing here? And so you'll get that question of what am I missing here, right? So you're kind of put in the expert chair, and to not answer, right, feels a little disingenuous. And so I usually caveat, well, with my experience of what you're saying, right, there's a lot going on here. This is what I'm seeing. And then I lay out what I see. And I say, I wonder about this. And I frame it as an open-ended question because, again, like you, I feel pretty eerie about, like, naming the thing for them, right? Like that, but there are certain presentations of autism and ADHD where you have to give more scaffolding, right? That is part of today as well. As we're going to talk about scaffolding, because intellectual disabilities are sort of like their own, like, flywheel, if you will. Like they totally like can screw with how you give recommendations, right? Because if a person can't comprehend what you're saying, you got a lot more going on than just what's in front of them. You've got it going on. How are they receiving the information you're giving? Which is kind of its own really challenging question that isn't something you can answer very easily. So good question. Assessing is clearly problematic. Do you have particular assessment forms that I use? So I use 3 primarily. I always assess for OCD and PTSD first. If one of those things is there, then I say, it's unclear if you have autism, go do an evidence-based treatment protocol on that and then come back to me. So far, every time I've sent somebody to do one, 95% of the time they don't come back. 5% of the time they do. And when they do, right, it's that example I gave you about OCD. That was autism, right? That looked like OCD at first, but was actually autism. So I use the autism mental status exam. I use the body perception questionnaire because I think a lot about the body. I asked that slide where I have all the disorders, right? Where I said I spend half my assessment on that. I wasn't lying. I do spend half my assessment on that because usually I can give them some pretty strong recommendations. And can be inconclusive about autism, but still give them next steps that might improve their lives, which I think is why people enter counseling. And so a lot of times it's referrals, but then when somebody like we know and we have a pretty strong clinical feeling, usually I work with a person before I do the autism diagnostic interview revised. But it's a really strong tool. What I don't like about it is that it's parent report, not kid report, but usually I do the autism mental status exam and the BPQ with the kid. I also use the Barclay's Deficits and Executive Functioning Scale, which we'll talk about when we get to executive functioning, which is later. And again, I know these things don't feel relevant because they're not like the SP, the IFS, the TFCBT, and the polyvagal theory, but I promise they are. It all connects. It's all connected to your heart. Is history of anxiety always a hint, if not being autism? It does frequently occur in it, but it's frequently when it's unclear and you don't know, it's a decent place to look to begin. There are lots of great evidence-based assessments, like the Yale Obsessive Compulsive Disorder Scale, or the Brown, I want to say the Brown is one too. I could be wrong about that. I might be misremembering my instruments. But it can be social anxiety. It can be misdiagnosed. But it's not always a hint. That's true. But it usually is a hint of we should probably start wondering about these things. So yeah, there's a lot of things that can happen here. Now, how is it that I still have 15 questions if I just answer those? So yeah, any other questions? Yeah. All right. So there's a lot going on here. Can you pass? So is there a way, Tabby, that we can grab these emails that people are still, or can we just give them my email?
Yeah, at the end, why don't you offer up your email for people with additional questions?
Okay, I can do that. Connor, thank you, Allison, for putting Connor. Connor was my missing person. Can you email me? So what I'm going to do is at the end, like what Tabby said, I'm going to put my email address in the chat. You guys can email me all your questions. And I promise that this stuff will connect more in the next module, but we did need to start where we are because there's so much we're going to talk about that we'll come back to these, how we understand what we understand. More, am I saying your name right? Go ahead and speak if you want, or unmute. I don't know if you can or not. Can they, Tabby?
Looks like they put their hand down, so they might not want to share.
Okay. You can, yeah. You can feel free to email me to your questions. As far as the ABA debate goes, I think the way it's portrayed is a pretty oversimplification of the history of ABA, the history of, I think it's a mischaracterization, and it has a lot to do with, so we have a source in the US called the New York Times that reported this a lot on this one study done by this guy named Ivar Lovaas. And really the basis for some of our most person-centered therapies like motivational interviewing are actually rooted in social learning theory, which is the heart of ABA. And so you can't really separate the two like people do. There's a lot of really bad research out there and some good on the effects of ABA on people with autism. And so I think it's a much more nuanced discussion. There's this guy named Gerald Patterson, look him up. He's fascinating. He had this thing called coercion theory, right? And basically what he found was in marriages and families, the harder you told someone not to do a thing, the stronger they did it, right? So like this weird, like, hey, we can't reinforce the way we thought we could, right? Also the basis for motivational interviewing and the writing reflex. Like they're one, they're not two, right? Like it just, I don't know. I get really frustrated with the debate, and I get frustrated with people who have autism like me who say it's abuse and like actually lack a cohesive argument about it, right? And then they cite Henny Cooperstein's research, which is market research and doesn't have scientific. Yeah, and you should ask the people who have had it, but you also need to be considering the clinical nuances of the thing, right? Like when kids are swallowing knives, right? Because pica's a thing, right? ABA actually might be really helpful, right? So like in these extreme circumstances and the other question is, how do you do psychotherapy with somebody with an intellectual disability? It's not clear cut. And if you look at the history of ABA, right? Like ABA were the first and only group of psychologists to say people with autism don't belong in institutions. They're the reason people like me got out of institutions. And so I struggle with the debate because I think it is missing the point. The point is nobody goes to school to hurt people, to my knowledge. At least nobody, as I understand it, who is a behavioral analyst, like really has gone to school to try to like make other people's lives bad. And I think they get demonized. Yeah, it's totally a power dynamics thing. I mean, I think there's a fair argument to be made that a lot of people who could have been ABA people could have like probably have some own things about their anxiety to work out. I mean, think about the structuring of it, right? Like, and I will tell you, I just had a client who I discharged because like I didn't give them enough structure. I'm way too like open and flexible, and like that actually can be really not harmful but not helpful to somebody who really likes structure. ABA is applied behavioral analysis. That it's a manualized form of B.F. Skinner's work of behaviorism. There's 7 principles to it. I'm totally not going to do it justice, but it's super nuanced. I'm really interested in this. So I want to be clear that there's a lot of really good research coming out on, I saw a comment in the chat. It's kind of a jump away and then we'll come back, I promise. There's really good research coming out on ADHD in females. And there are just great resources out there on this topic. I'm trying to become more familiar with it. I'm still like just in my infancy of understanding. But there is really great stuff. I had a student last semester in child psychology, wrote a great paper. I'm happy to post it. I'm sure she'd be thrilled to hear from any of you about it. Just to know that people are reading her work. But she's a female and she wrote a paper on ADHD. So I had my students write a problem statement in a population and then a solution. So I'm going to give you a resource. Her paper is a great resource and a great starting point. I believe in, yes, I do think ACT works with neurodivergent clients. And then I want to come back to the autism ABA thing. So to come back to the ABA thing, like, I think it just, as far as the structure piece goes, right? Like, it depends on your client. Some clients love structure, others don't, right? And ABA is all about doing things in a structured, organized way, right? Which for our clients who don't have that, or for our clients who thrive on that, that's great. But like for those of us who don't, like myself, it's not so great. And so I don't think it's a one size fits all answer.